Hello, everyone. My name is Sadia Maksood, and I am Program Manager at Behavioral Health Division within ICJI. Today, we are hosting a webinar with Division of Mental Health and Addiction regarding recovery initiatives across the state. We have three amazing presenters with us today who will share valuable information about recovery support work groups and importance of recovery data sets. I would like to briefly introduce each one of them. We have Erin Quiring, who works for DMHA Indiana as the Assistant Deputy Director for Quality Improvement. Her responsibilities at DMHA focus on the monitoring and improvement of treatment services provided by DMHA's certified, licensed, and funded mental health and substance use agencies. Erin is thrilled to be the part of team using data to expand access to quality recovery support throughout the Indiana. Next, we have Amy Brinkland. Amy works for the DMHA as the Bureau Chief of Consumer Affairs. She is also the chairperson for the National Divisions of Recovery Support Services. Her responsibilities at DMHA and as a national chairperson primarily focus on the expansion of quality peer recovery and recovery support services initiatives. She is super excited to be the part of Indiana's team advancing recovery support services and setting the bar nationally for the collection of recovery data. Last but not least, we have Ari, who works for DMHA as the Director of Behavioral Health Integration. His responsibilities at DMHA focus on progressing the level of integration across the continuum of care for behavioral health and substance use disorder providers in Indiana, as well as increasing the integration of data sources among providers and at the state level. Ari is very excited to work with the Recovery Support Workgroup and with its strategy to expand and utilize the recovery data. Without further delay, let's go to our presenters.
All right. So first, to give an overview of what we're going to cover today, we're going to talk about first who we are and give you an idea of where we sit in state government and what we do. We'll talk a little bit about where our data processes are and how we're pulling data, and then spend the bulk of our time getting into the data sets that our group has been looking at specific to recovery supports. So to give kind of the quick overview, DMHA, the Division of Mental Health and Addiction, is under the umbrella of the Family and Social Services Administration, which is headed by Secretary Sullivan, who then reports to the governor. And FSSA includes other divisions such as Family Resources, Aging, Medicaid, among others. You want to hit slide, Amy? So DMHA updated its mission and vision this year. Our updated mission is to champion mental health promotion and substance use disorder prevention, treatment, and recovery systems that are high quality, seamlessly integrated, and accessible to the people and communities of Indiana. And under each of those areas, high quality systems, seamlessly integrated and accessible, there are values. And specifically, what we'll kind of look at today are our values of being data-driven, evidence-based, and being peer-driven as well. So practically speaking, that means that we certify and license mental health and substance use treatment providers. We conduct follow-up and monitoring of those providers, as well as we operate state psychiatric hospitals and provide funding for a variety of prevention, treatment, and recovery services. And then Ari.
Thank you, Erin. Why data and why now? As Erin stated, DMHA's mission, one of our core values that we're looking at, is increasing high quality systems that are data-driven, evidence-based, and peer-driven. Specifically, we want to use data so that we can better follow through on our mission and perform at a better way when it comes to our functionalities. And one of the things that we look at are the different data sources that we have, and also utilizing other data systems and other data groups that are available to us both within FSSA as well as outside of FSSA and partnerships that we have made. And one of those partnerships that we have made are with the government's or the governor's group, the Management Performance Hub. And the Management Performance Hub are a group that are under the governor and have executive permission to make connections with a lot of different folks across the state of Indiana that we at FSSA generally may not be able to make those immediate connections. And they are able to do some amazing work through their analytics as well as visualizations. And I would like to share one such visualization that we've done with MPH in a specific partnership to look at. In this case, it was emergency department visits, and it just, I think it does a great job of highlighting the Management Performance Hub's abilities. Give me one moment. All right. Now, on this screen, what we see is that they were able to actually take a look at through connections that they've made with IHI, the Indiana Health Information Exchange. They looked at emergency department visits, specifically looking in this case for suicidal and harm to others. But what they did that was very specific and interesting in this case was not only were they looking at ICD codes, which we have access to through claims, but they connected through IHI to look at ICD codes on emergency department visits, but also to look through keyword searching of the clinical notes. One of the big problems when it comes to emergency department visits for suicidal or self-harm or harm to others is they may not be the primary diagnosis code that is associated with the claim for the emergency department visit. So those keyword searches were really helpful in expanding the data collection of how many folks are experiencing suicide or harm to self or any kind of other harmful ideations. And so here what we see is a Tableau visualization, which you'll see a couple times in this presentation. And Tableau is a visualization tool that just allows us to visualize data in an effective way that's integrative. And what I mean by that is you have a state map here that allows you to click on a single county, and then what will happen is the rest of the visualizations will change accordingly to display only in that county. And so this is kind of indicative of what MPH is able to do, and one of the resources that we are wanting to further use in a partnership with them in order to increase our data collection efforts at DMHA. Going to stop sharing now. And then if we go back to the PowerPoint, please. Okay. So more FSSA data initiatives when it comes to data is to expand our data catalog. And so we're looking at increasing the what we have cataloged and put in the library of the different data sets that we have. And that includes the data sets that we capture here at DMHA, as well as those that we catalog that we can connect with at the EDW, which is the Enterprise Data Warehouse of FSSA. And another initiative that we have is to expand our data literacy and access. And these things really started over the last year, not only in 2020, but in 2019. Recently, in order to expand data literacy, FSSA has rolled out Tableau and data analysis trainings that have been very helpful to increase everyone's, and by everyone we mean staff's, understanding of data, as well as understanding of how data is visualized and matched and collected and presented, and how to better communicate with data teams in order to visualize and utilize this data. Our hope is that as we continue to move and continue to progress towards our completing our mission, we use data in this method, and that's really the data-driven aspect that we're seeking. Next slide, please. All right, and Aaron, back to you. Or
Thank you, Ari.
sorry.
Thank you, Ari. So I'll go ahead and start from here. So my name is Amy Brinkley. And one thing I want to say before we jump into this data set about everything that Ari just shared, it is really exciting that we have a governor's executive order that allows us to collect de-identified aggregate data from all of our state stakeholders, which it's an exciting time for us to have access to that data, to be able to holistically look at what's happening in the state. Because having the siloed data sets, we're just not getting the full picture. And so for us to collectively and holistically be able to look at things and identify gaps and move forward in a cohesive manner that's actually supportive for folks is really exciting for me personally. So another thing that I'm very excited about is recovery, and specifically recovery data. So one of my favorite people, Bill White, talks about the collection and lack thereof of collection of recovery data. So, we've spent, and this is one of the things that he says that I've really been inspired by. We've spent decades and decades studying the problem, and we're hard pressed to study the solution. So, we've got all of these books and books and books on addiction and substance use disorders and mental health issues, but you're hard pressed to find some real hard, solid data on recovery. And so that's why I'm so super excited about what we're doing. At the Division of Mental Health and Addiction, we have a subgroup that is an advisory that operates in an advisory capacity to DMHA, and that's the Indiana Recovery Council. So our Indiana Recovery Council issued a survey this year. Well, it was back in August, and it was live. The survey itself 4 weeks. The targeted audience of that survey was people with direct lived experience who are accessing treatment in Indiana. Our primary goal was really to identify barriers to treatment and recovery supports and to hear from consumers directly with no filters. So Aaron's going to talk here in a few moments about our consumer satisfaction surveys. And so our consumer satisfaction surveys actually go through our community mental health centers. So one of the benefits of the IRC survey is that it really went through the grassroots, through the recovery community itself, so that there were no filters. So there's no, barriers or potentially, if somebody gets their survey from their provider, they may, they want to rate them high. They want to give them, make them feel okay about it or whatever. So just having no filters is just hearing from the consumers directly without filters, what we really wanted. Some of the successes for the IRC survey are that we had just under 200 responses. There were about 19 questions to about 6 minutes to the survey. 100 people, we offered the survey anonymously, but we had 100 people that offered contact information because they wanted follow-up. We ended up with, I believe it was 16 pages of open-ended responses. And people, what we found through the survey is that people just wanted to be heard. So a lot of people were experiencing a lot of different barriers across the state, barriers accessing treatment and recovery support services, and they really just wanted to be heard. I mean, that was the overwhelming response that we took from the whole survey. So we did ask some specific questions, and we're not going to get into them all today. But we did ask some specific questions as it relates to length in recovery, both mental health and SUD recovery, and then we asked about their lived experience. So the lived experience breakout, I think the only thing that was surprising about that is that we had more people that identified as having mental health only lived experience than we did with the SUD only lived experience. And with our current opioid climate, I think that was a little surprising. Not too surprising is that 50% were co-occurring. We had about 11% that identified as family member. So one question, our very first question on the survey, is there anything missing in your daily mental health or addiction recovery process that you can think of that is related to health, home, purpose, or community needs, which is SAMHSA's 4 dimensions of recovery? We actually laid that out for folks. We identified purpose as being exercise, hobbies, education, or employment. Home was identified as being safe and affordable housing. Health was identified as access to treatment, medication, insurance. And then community was identified as peer support services, social supports, and community supports. And you can see purpose was our leading gap that people were missing in their daily recovery journeys. And then health was at 47%. And I'll tell you, just from reading through all of the open-ended responses, the pages and pages of open-ended responses, access to treatment was really leading the charge here, at least as far as our open-ended responses went. People were really struggling getting to the services that they needed or that they wanted. So the next data set we're going to talk about is the Recovery Support Workgroup. The Recovery Support Workgroup was one of the first initiatives that I kind of stepped into in my role at the Division of Mental Health and Addiction. It was and is a work group that was developed under MAPAC by DMHA to promote and develop statewide recovery supports with the goal of community integration, recovery for persons with mental illness and or addictions. So the work groups, actually Erin, so I've been part of this work group now for about 3.5 years, but Erin's been part of this work group longer. So Erin, why don't you go ahead and take it from here and then maybe start us through the data sets.
Okay, great. And as Amy mentioned, I've been with the group just after its founding in 2012. But one of the first tasks that the group did was to gather data and do a gap analysis statewide, which has become the basis for most of our work. And you want to hit the slide, Amy? So initially 2 surveys were created. One went out to consumers and one went to family members, exploring recovery supports. And the results were pretty consistent between those 2 surveys and identified the recovery supports you see on your screen, personal support networks, peer support, hobbies and interests, prevention and wellness, and safe and affordable housing as kind of the top 5 most important recovery supports, as well as ones that were lacking or missing. And you'll see that they overlap with SAMHSA's framework for recovery supports as well. And then on the right, you'll see folks who've been involved in the work group, and we've tried really hard from the beginning to make sure that we have various stakeholders from other state agencies, from the community, folks with lived experience. And certainly over the years, we've gone through some transitions in composition of the group as well as focus of the group. And we've spent the last couple of years reassessing those recovery supports since the initial analysis was back in 2012 to see if folks were still saying that those were important recovery supports for them. And in all of those kind of touches and data collection that we have done, that has been reiterated, and they remain the focus of the work that we're doing. And so we're really excited because we're going to start moving into a recommendation phase, and that's where this data becomes really, this data focus becomes really important. And so we've engaged, as of this year, a contractor, Essential Virtual Solutions, who's been helping us with establishing processes, making sure that we can work seamlessly as much as possible, and giving us kind of our tasks as it relates to each of those recovery supports. We're actually going to be breaking into sub-work groups to look at each recovery support and make substantive recommendations on how we can improve access to them. And so again, data will be a big piece of that. And so we're going to look at a couple of the different data sources that we've identified early on as likely sources that we'll continue to pull from. So Amy, if you want to.
Yeah, I want to say something too real quick, Erin. So part of us breaking into the subgroups, part of the reason why that was so important is because, as you saw from the previous slide of our state stakeholders, we have some really strong leaders in these areas, and everybody was coming to the meeting with different interests, different perspectives. And so we were really struggling to achieve anything or having very clear, identified, actionable goals because, DWD was coming to talk about housing, NAMI was coming to talk about mental health supports, all of these different varying focuses, and it was just really distracting for the meeting. So one of the beautiful things about our subgroups, sorry, Erin, yeah, one of the beautiful things about our subgroups is that they can break up into the subgroups. and focus, oh, I hit the wrong button, and focus on these specific gaps and deep dive into these gaps and focus on data sets. And so by doing that, we feel it's going to be strong. Then the subgroups will then report out to our larger work group. So there you go, Erin. Sorry about that.
Yeah, no worries. So the first kind of set of data that I'm going to share with you is Amy mentioned our annual satisfaction survey, and this is something that we do every year and have for many, many years as part of our federal reporting requirements, because we do have to report back to SAMHSA, the Substance Abuse Mental Health Services Administration. And so we've been doing a survey with adults and with children through our community mental health centers, as well as in recent years, we've added some of our other funded providers. And they're standardized surveys, but we have some room to add some questions. And we've done that over the last several years related to recovery supports, and have gone through a few different questions that we've had on there. But the set that we asked in 2019, which is what you're seeing on the screen, we feel good about and will continue to ask. And these were on the 2020 survey that went out in September. And so we're able to get feedback directly from, excuse me, the folks who are in treatment. So as Amy mentioned, we do recognize that one of the limits of this data set is that it skews very positive, because these are folks that are engaged in treatment. They're coming in generally within the survey period time, which means that they're active and involved. It would be interesting to see what happens this year, because of course most providers have been doing telehealth and remote work. But we asked respondents to talk about whether or not their provider offered them opportunities to access peer support. And you can see it's strongly agree and agree. So generally, again, positive. We asked them about hobbies and interests. Again, skewing positive. And this year, what we'll be able to have is a comparison of last year's data so this data here to what the responses were this year. And we can also start, as we've kind of identified these as the questions that we're asking, we can get into more specific, like provider level or county level views of this data. This that you're seeing here on the screen is everybody statewide. And so we may see that in different counties or different providers, we don't have the same level of positive response. And this is nice too, because we generally get about 6,000 or 7,000 adult responses. And then for youth, we usually get about 5,000. So it's a pretty big sample that we look at. And then another data set that we have access to and are looking at how to kind of work into the process is what we call Dharma data, kind of broadly and generally. But what we're really talking about is data from the CANS and the ANSA. And those are assessments that we've required our contracted providers to use for many, many years, over 10 years. And they are assessments that are done at intake and then roughly every 6 months, and contain a range of items designed to assess individuals' needs and strengths. And then all of that information is required to be put into Dharma, which is just the data system that all of that information gets kept in. And we find that there are several items within the CANS and the ANSA that overlap with those recovery supports. And so those are items that, we can look at. And so some of those items are here on the selected report. We have a contract with the IU School of Social Work, and they have been working with a contractor to create some of these specific reports that allow us to see outcomes. And so this section over here are strengths that are generally rated in the assessment, and we want to see those over time go up. And then these over here under functioning are needs. And so over time, we want to see those go down, indicating that those needs are getting resolved through treatment. And they're also working on some newer reports that'll be a little bit more nuanced. You'll see, with these numbers, they're fairly small amounts of change, but that's because they rely on a bigger change. So they're looking for a need to be completely resolved before it gets kind of counted as in this change that is represented on the chart. And so the newer reports are looking at folks who've had at least some improvement, and not just that they've resolved their need all the way, because depending on what the need is, or the strength is that, that can take more time than the 6 months or the year that we're looking at within the report. And
Erin,
then also,
I would
go ahead.
Oh, I'm sorry. I was going to say, I would even mention too that we're very interested in the overlap between what we're seeing here on the screen and SAMHSA's dimensions of recovery, because when we're talking about employment, we're talking about purpose. When we're talking about natural supports, we're talking about social supports, and those were the identified gaps in services specific to Indiana. So this is very valuable information for our groups.
Yeah, and the last piece I'll say about it is that kind of as we were talking about earlier with these broader data initiatives, some, if not all of Dharma data is going to be moved into some of these other systems that'll make it easier to create visualizations similar to what Ari showed through Tableau, that will allow us to manipulate the data a little bit more and even kind of dive in a little bit further to some of this data in a more accessible way. So I will stop sharing and turn it over to Ari. I think.
Thanks, Erin.
There we go.
All right, perfect. And now on the PowerPoint slide, the next piece is SDOH data. And SDOH stands for Social Determinants of Health. And I'm going to share a couple different Tableau dashboards here in a second. All right. Now, on this screen, what we see is the Hoosier Health and Wellbeing Atlas. This was started back in 2018. I joined the Recovery Support Workgroup, I believe, around that time, possibly beginning of 2019. And at the time, I was a data analyst under the Director of Behavioral Health Integration. And that's really where I came in, is to take a look at and help Amy with some of the that they had started, and they had done the gap analysis. But when we heard about the social determinants of health and what FSSA was doing in order to take a look at social determinants of health, we got really excited. And what FSSA did is, for every individual that was applying online for either health coverage through Medicaid, SNAP, or TANF funding, all of those applications included a 10-question survey. And that 10-question survey was focused on the social determinants of health, anywhere from not having enough food or money for food in the last 12 months, down to not engaging in regular exercises. And what they did is they asked for all these respondents to submit for these 10 survey questions, as well as to provide age, ethnicity, gender, marital status, and education demographics. And over 2019, approximately 325,000 assessments were collected. These assessments are representative of the heads of households that were applying for those coverages. So that's important to realize, as it may be representative of a larger family, each assessment. And these assessments could be done multiple times and would be counted as a secondary assessment. So when we first heard about this data, we were very excited, and we were extremely excited that recently it was published to the FSSA website for everyone to see. And as you can see, this is visualized on Tableau. And what we were excited about is it allows us to kind of look at, specific counties, to also take a look at if there's a specific age group that we would like to see, and to see what those responses look like and how they're represented among the demographics as well as geographic location. And what we were interested in was merging this data set with what we viewed as the folks of interest for the Recovery Support Workgroup. And what we did is we contacted FSSA executive leadership, and they gave us permission to match with this data set. And so we took a look at all of the folks that had applied for coverage, whether it was health, SNAP, or TANF, and matched and attributed them towards those that in 2018's calendar year had provided some sort of diagnosis of either SMI or SUD or both diagnoses at some point in 2018. And so over here is the result of that. The merged data set revealed approximately 4,500 folks that in 2018 had some sort of SMI or SUD diagnosis and matched along with those that had responded and had previous Medicaid coverage. So there is a limitation to the data set in that regard, but it still provides us with an ability to take a look at some specific gaps that we had highlighted from our gap analysis, and to look at those specific social determinants of health areas and how they're looking across demographics. And those specific questions that we highlighted we wanted to take a look at were whether or not utilities have been shut off in the last 12 months, fear of not having stable housing in the next 2 months, problems getting childcare, either cost or transportation preventing seeing a doctor in the last year, fear of being hurt in the home, or not engaging in regular exercise. And what you can see is we also took a look at demographics and displayed them on this dashboard. And that allows us to really take a look at each one of these areas. And you can see the tooltip will show you for each county what those results were for each of those questions, but to take a look at how those demographics play into each of these questions. And so we're really excited to use this. And what we're doing actually right now is expanding the analysis to the next stage after we've taken a look at this data set. We're expanding it to 3-year look back on claims with the specific intention of trying to capture those that may have either fallen out of having service prior to 2018 or coverage, I mean, not service, or may have been incarcerated in that time period. But also, the next step is on top of that expansion of the looking through ICD claims, we're also going to be looking at those that did not have either of those claims to identify the differences between those populations of those that either have an SMI or SUD identified, as well as those that do not, and see how those differences in demographics and geographic areas really can play in and help inform us on decision making in the future.
Ari, can I say something? Oh,
absolutely.
I was going to try to, keep sharing because I wanted to reference something on there. I'm sorry, I tried to catch you.
No worries.
I just wanted to reference the questions. So I wanted to mention that those questions that Ari shared, the utilities being shut off, fear of not having stable housing, those the recovery support work group identified as falling under the gaps that were previously identified. So there's a trend here. The recovery support work group is trying to be very specific in our data sets and what we're looking for. We didn't need the additional questions because they weren't identified by consumers as being a gap in a recovery support need, if that makes sense. So that's why we took out a few of the other questions, because not engaging in regular exercise fell under hobbies and interests, fear of being hurt in the home, and fear of not having stable housing. Both of those fell under our safe and affordable housing section. So all of these were identified as being gaps by our consumers. So just wanted to mention that.
Absolutely. Thank you, Amy. And now I think it's you. I'll stop sharing with the recovery data platform.
Let me unmute and go back to sharing my screen. Can you guys see that?
Yes.
Okay. I think I moved around a little bit, so let me get back where we need to be. So the last data set that we're going to talk about is the recovery data platform, and I'm going to try to move through this a little bit quicker. The recovery data platform is a pilot project. Well, it started out as initially as a pilot project. We contracted with Faces and Voices of Recovery, otherwise known as FAVOR, which is a national organization, and we purchased a cloud-based recovery platform from them to start collecting recovery-specific data. So the platform itself is housed within Salesforce, and we contracted with FAVOR for 2 years, and we've purchased 200 licenses. And those licenses will be utilized by our peers. So we have peer support service providers around the state in community mental health centers, community-based settings, working for independent treatment providers. There's some in emergency departments. We have peers within our reentry courts. You know, we kind of have peers infiltrating, you know, just varying facilities and working in different capacities. So the licenses will actually be utilized by our peers. So the peers themselves will be collecting the data for us. Our current partner, so initially we had started out with a plan to have this as 4 pilot sites. The pilot sites were going to be Inwell, NAMI, West Central Indiana, Choices, and the Landing. And their focuses were going to be youth. Their focuses were going to be specifically for their organization. Primarily, one was going to be for youth. Primarily, one was going to be for mental health. One was going to be addiction recovery. And another was going to be within the recovery residences. In the process of executing that contract, COVID kind of sprung up on us earlier this year. And so as part of DMHA's response to the COVID crisis, we had contracted with the Indiana Recovery Network to start our regional recovery hubs. So we have a contract now for the regional recovery hubs with the IRN, and they currently have 16 organizations, and we are actually expanding that to 20. So by early spring, we'll have 4 more organizations at least. And each of those organizations have up to 10 staff, but really they're primarily focused on hiring at least 5 peer support staff. So the peers within each of the regional recovery hubs will have a license to collect the recovery data that we're about to talk about. So for the purposes of those, the LCCs, I think it's important for them to note that the 20 sites are scattered across the state in a regional model. So we have recovery sites in Southwest, Southeast, Northwest, Northeast, and Central Indiana. And folks who want to access those sites or any services that they're offering free of charge, they can call 211, or there's a website that they can go to too. But I think the recovery sites are very beneficial for what the LCCs do in helping people access treatment and services and get connected to the supports that they need. So for the RDP, there's a couple different things that the RDP does. So it tracks things as simple as general interactions, or as in-depth as a formal intake or a brief intake. It can track things as simple as referrals. There's also a recovery management plan. So if the regional recovery site, if one of the peers at the regional recovery site is working with someone who doesn't have insurance, so they're probably going to be coming back on a regular basis for a few months, that peer can actually create a recovery management plan with the person they're serving that's inclusive of SMART goals and action plan, etc. And then I think one of the other things that I want to talk about is the recovery vital signs. So I think this is the one thing I'm personally most excited about when it comes to the recovery data platform. So when you go to the hospital, or when you go to the emergency room, or when you go to the dentist, or when you go to any kind of a primary care doctor's visit, what's the one consistent thing that they do? They check your vital signs. So they check your temperature, they do a blood pressure check. They just do that general vital sign check. So what Favor has termed as recovery vital signs come in the form of scales, and they're very short, 10-question, self-reported scales that really tell us very quickly in a snapshot where this person's at from a week-to-week basis. So the 3 that we're going to talk about is the BARC-10, or the Brief Addiction Recovery Capital Scale, the Engagement Scale, and the Lifestyle Scale. So the first one we'll jump into is going to be the Lifestyle Scale. So some quick facts. This will ideally be done upon intake and maybe 6 months thereafter. The main thing that we're hoping to capture with this particular scale is the healthcare insurance question, because if folks are receiving services at our regional recovery hub, which is a community-based partner, and they have insurance, we want to make sure that we're moving them into formal treatment if they need it. For the BARC-10, this is something that we've just previously not done in the state of Indiana, and a lot of states are starting to get on board, and we're kind of leading the pack, and that's a good feeling, but it's extremely important that we're actually capturing this data. So one of the things that you've probably heard a lot about, if you work in the field at least, is recovery capital. So the Brief Addiction Recovery Capital Scale is a way to measure that. ongoing. So it's qualitative in nature. It's about 10 questions. And the person has a 1 to 6 scale of strongly agree or strongly disagree. Some of those questions include, there are more important things to me in life than using substances. In general, I am happy with my life. My living space has helped drive my recovery journey. I take responsibility for my actions. I am making good progress in my recovery journey. So as you can see, it's very qualitative in nature, but it's a snapshot of where that person's at on a week-to-week basis. And over time, that will ideally tell us what we mostly already know, but we just don't have the data to prove. And I'll get into that more in a minute. The second or the third scale is the engagement scale. So this scale is kind of 3 in 1. The outcome rating scale is questions like, how have things been going for you socially? Rate how things are in your life overall. Thinking back over the last 7 days, how have things been going in your relationships? So it's really just how is this person feeling overall? The cravings rating scale is kind of in the title. It's just about how their cravings have been that week. The relationship rating scale is really about how they're connecting. This will be very beneficial for peers who are providing peer services. It'll be beneficial for the supervisors so they can work with the peers on how they're connecting with the people they're serving. And it would be a great conversation starter for folks to just improve upon their services that they're providing. So the idea here is that as we're collecting these 3 different data sets, the RDP allows us to create our own reports. So part of creating our own reports is that we can crosswalk any of those specific scales and data sets. So I'll just give you an example. So if I'm working with Christina, and I know that, and this goes back to what I was saying a minute ago about telling us the stories that we already know. Like I am personally a person in long-term recovery, and I know from my own recovery journey that the first 6 months to a year to 2 years, I mean, it was a struggle, right? When people are newly physically sober, coming out of a substance use disorder, there's a lot of emotional highs and lows. And so decision-making is impacted. Relapses are common. These are kinds of things that if you've been in the recovery field at all, you know that these are kind of common. So by us capturing this data, we can kind of start to tell the story of what we already know and maybe target funding to address some of the gaps in services. So one example, I'm working with Christina. I know that she's just broke up with her boyfriend. I know that she's struggling financially and she just lost her mom and she's relapsed 3 times in the last 6 months. So if I'm her peer support service provider, I can go back and check her chart and check her vital signs and see, okay, where has Christina been at over the last 6 months? Oh, look, Christina's relapsed 3 times. All 3 of her relapses show that she, as far as her, if I'm looking at the chart of the scale of what you're looking at now, her relationships rating scale, she wasn't connecting to people. She reported a 4.5, 3 times. And then her cravings rating scales were skyrocketing and went above a 10 3 different times. And those were the crucial moments where she relapsed consistently over the last 6 months. Then me, as her peer support service provider, I can potentially get in front of that. And so there's a prevention component here of tracking this data in real time and being able to get in front of and elevate the level of services for this person prior to relapse or prior to the crisis. And so that's something that I'm personally very hopeful for with the RDP, that we can start using the recovery data platform in a lot of useful ways, including the preventative side, and really just helping meet people's needs no matter where they're at on the recovery journey. I know that for people in recovery, myself included, in the first 3 years, I mean, that's a crucial time, and it's not always something tangible. Like there were plenty of times where I just, the feelings of hopelessness, and I'm not going anywhere, and this isn't working, and I don't know what I'm doing and why I'm trying this. The recovery data platform is actually tracking progresses, and the recovery management plan. All of this will be beneficial in showing people where they're at on their recovery journey and solidifying that for them and encouraging them along the journey. So there's probably many more things that we can do with this. It's pretty early in the process, but we are very hopeful for, where we go next with this. And that's kind of all I had for our presentation. We have, we're collecting all of these different data sets in varying ways, and we're going to continue to collect it. And hopefully in a year, we're going to have some really awesome outcomes to report. Aaron, Ari, do you guys have anything? And that's all we have.
Okay, I would like to thank all our presenters for providing us the insight about the working and findings of the recovery support group and data set. I'm sure that this information will be really helpful for LCCs, especially I am really thankful to you, Amy, for mentioning about the recovery sites, because I think this is something LCCs would like to engage and refer people. If anyone has any question, kindly reach out to our presenters who will be happy to help you out. And thank you so much for taking a time for this webinar. Have a good day.